Good afternoon and welcome to the ICTS Precision Medicine session at Venture Cafe. I'm your host, Rob Culverhouse from the Department of Medicine at WashU. We meet on the third Thursday of the month at 4 o'clock and our sessions last 50 minutes. Our mission is to connect innovative biomedical science generated at WashU, SLU, and MU with entrepreneurs and businesses in the St. Louis region. We hope these sessions stimulate your thinking, and we encourage you to share your insights and your ideas with the speakers after their presentations. In case you'd like to follow up with either of today's speakers, you can find contact information along with information about past and future talks on the WashU Precision Medicine website. That's ictspm.wustl.edu. Look under events, and also the web address should be listed in the chat box. Please feel free to unmute yourself at any time. Anytime you have questions, you can also use the chat function. Today's presenters are from the WashU School of Medicine. Justin Sachs and Matthew MacEwan will tell us about their paths to commercialization for products related to wounds. Matthew MacEwan is founder and chief scientific officer for Acera Surgical, a bioscience company developing and commercializing groundbreaking soft tissue repair products. He's an MD and also has a PhD in biomedical engineering. In addition, he is co-founder of the Center for Applied Neural Engineering in the WashU Department of Neurological Surgery. The center develops innovative technologies for neuroprosthetics and peripheral nerve interfaces. Justin Sachs is chief of the Division of Plastic and Reconstructive Surgery at WashU, coming to WashU after a decade at Johns Hopkins as Vice Chair of Clinical Operations and Director of Oncological Reconstruction. He holds an MDA in Medical Services Management from Johns Hopkins and is co-founder of the Biotech startup Lifesprout. His research focuses on tissue engineering, vascularized composite allotransplantation, and vascular perfusion assessment. His clinical interests include reconstruction of all forms of acquired oncological and traumatic defects. So thank you both for being with us today. And Dr. MacEwan will start us off. Engineering nanofiber matrices are effective scaffolds for promoting new tissue formation, but have not been widely adopted clinically. Matthew will tell us about his efforts to develop and commercialize the first resorbable synthetic nanofiber matrix approved for human clinical use. So welcome, Matthew.
Perfect. Thank you so much, Rob. It's a pleasure to be here, and I'm really excited to share the stage with Dr. Sachs. About a year ago now, Dr. Sachs and I sat down and realized we both had a great interest in translational medicine and new technologies, and as a result, started a great collaboration around new technologies for treating and preventing chronic wounds. And so I'm very excited to share both my story and then have Justin share some of the great technology that he's envisioned as well. So really appreciate the opportunity today. The story that I'd like to share is sort of our pathway developing unique technology here out of the biomedical engineering department, specifically for the treatment of chronic wounds. Hopefully everyone can see my screen. There we go. So when I was here doing my training in the MD PhD program, I had the opportunity to work in the Department of Biomedical Engineering for my PhD, and got very interested in the concept of using nanomaterials to treat soft tissue defects and other types of wounds, and wanted to share our experience in really translating this technology into the clinic, and specifically starting a company called Acera Surgical, which is still based here today and really doing some really innovative work here in the soft tissue repair space. So first of all, in terms of the impact of chronic wounds, it's really mind-boggling how critical the treatment of chronic wounds are to our overall health system. Some recent data shows that about 15% of all Medicare beneficiaries are affected by chronic wounds, and annually cost the system about $30 billion. These are a large problem both for patients and for insurers and healthcare systems as well. And as a result, there really is a significant need for new solutions that can treat these types of difficult wounds. And so in the lab, we really started looking at, what are some different approaches that we could use to treat or better treat chronic wounds. And what we found was one of the biggest issues with chronic wounds is that essentially the extracellular matrix that makes up the tissue inside these wounds is essentially degraded. And there's so much inflammation going on that really new ECM cannot set up. And as a result, cells cannot come in and establish themselves and build new tissue that's needed to sort of repair these chronic wounds. And so if you look back at the history of different solutions for these types of wounds, like diabetic foot ulcers, venous leg ulcers, pressure ulcers, what you find is there's a number of different technologies that were used to try to address these chronic wounds, ranging from autografts such as split thickness skin grafts, all the way to animal-based materials like xenogenic porcine or bovine collagen materials, all the way to some very fancy biologic solutions like amniotic tissues and biologic skin substitutes. But if you look at all these different options, what you find is they're really just trying to restore the lost extracellular matrix. And they're just essentially a lot of very high cost and very fancy approaches to how to try to reestablish ECM in these wounds and provide a scaffold for new cells and new tissues to grow on. And our thought process is, while there's a number of interesting, allogenic materials out there, they're limited by a number of critical issues such as harvesting and tissue tracking and biocompatibility. And so we thought, could we use sort of the cutting edge of nanotechnology and material science to better engineer a scaffold and a matrix that could help some of these chronic wounds to eventually close and heal and reduce that risk of chronic infection and morbidity. And so as a result, we turned to a really interesting technology that we were developing and working on in the lab called electrospinning. It's a unique way of taking resorbable polymers and actually forming them into nanoscale matrices that emulate the structure of native extracellular matrix. So the process is very interesting. We take dissolvable polymers such as you'd find in Vicryl or PDS suture. We dissolve them into solution, and then we actually spray them through very small needles to create these nanoscale resorbable fibers that you can see on the right-hand side. And what's really unique about these materials and these nanofibers are that not only are the fibers hundreds of times smaller than native human cells, but they also have the same non-woven fibrillar architecture as native ECM. And as a result, what we found was that cells have a unique ability to attach onto these nanoscale fibers, grow along them almost like cars on a highway, and eventually set up shop on these fiber matrices and start to produce new ECM and new tissue. And so really it's the biomimetic quality of these fibers that really gives them this unique biologic potential as a synthetic tissue scaffold. So this just kind of gives you a sense here, this little video of how these how these fibers work. This is actually a culture of human fibroblasts, where the fibroblasts are actually attaching onto the fibers, growing along the fibers, and really interacting with the material in the same way it would native extracellular matrix. And so it shows the power really of these fibers as a tissue scaffold. In addition to that, we started doing a number of interesting cell culture experiments, a number of interesting preclinical studies here at the university. This is a great study just showing how fast fluorescently labeled human fibroblasts can grow into this material. Essentially, the fluorescently labeled cells at the top left could completely populate a circular piece of this nanofiber material within just 48 hours. And so we really found that this material had a unique ability to support rapid cellular ingrowth and migration. But beyond that, we started looking at large animal studies, comparing the fiber matrix to other existing gold standards that we have available in the ORs and the clinics. In this case, we were comparing it to Integra's bilayer wound matrix product, which is a well-known sort of skin substitute or tissue product that's available for use in treating these wounds. And we found that these nanofiber materials could actually not only close these wounds more quickly than existing products, but also do so with less inflammation, better quality granulation tissue, and even significantly increased neovascularization. So not only were these sort of unique and novel materials, but they were really bringing some very important clinical benefits to the healing process. And with that, we really saw that this technology needed to be developed and deployed in the clinic. And so as a student, I started a company which is now called Acera Surgical. And we went through a preclinical development phase and eventually got approval for a product called Restrata. And the important part about Restrata is this is the first of its kind in utilizing this nanofiber technology as what we call now the synthetic skin substitute. Recently, we just got this approved via Medicare, and CMS has actually granted a whole new class of products and technologies under the synthetic skin substitute class due to some of the work with Restrata. So really excited now that we have this material out and available both here at BJH and around the country, and we're seeing some really exciting results with the product now clinically. Wanted to show you a few of those cases here just to highlight the efficacy of the product. In this case, this is sort of just a quick overview of how we tend to use it in treating chronic wounds. We recommend initially doing a debridement of the wound, as you can see on the left. We then take the material out of the pouch, cut it down to size, staple it, suture it, or steri-strip it in place, as you can see here in the middle. And then we do an overlying non-adherent dressing and appropriate secondary dressings to dress the wound. And using this approach, we've been able to really heal some very challenging wounds that were reticent or essentially unresponsive to even some of the most advanced biologic therapies that are out there. This happens to be a chronic wound out of Texas. As you can see on day 0, this is a gentleman who had very advanced diabetes, had already had his first toe amputated and had a wound with exposed bone. We meshed the product, put the product on at day 0. Within just 2 weeks, that wound had completely granulated over the bone, and with the second application, got to full healing in about 8 weeks, which was a great result for this gentleman. Interestingly enough, this gentleman actually was able to keep his foot and was able to preclude either a transmetatarsal or potentially a below-the-knee amputation. So a great result there. We're also seeing some great results in deep surgical wounds. So in this case, we're putting the material into deep wounds following sarcoma resection, and we're seeing these wounds fill in and eventually reepithelialize and close, which is great, especially in the case of folks who maybe can't undergo a split-thickness skin graft or flap closure. We also see some great applications in lower extremity trauma. This is a case out of Chicago where we actually use the synthetic matrix to build up granulation tissue over exposed tendons and eventually bridge to a split-thickness skin graft. Additionally, another great use for this that we found is using it over wounds with exposed structure. Again, in this case, exposed tendon. This material is able to help granulate tissue over that exposed structure and eventually promote that reepithelialization. Finally, I'll just skip a few of these here. We're also using it in some burn settings, which is another interesting one. This is a pediatric burn case out of South Carolina, and seeing this as a very a very nice low-cost option to really help promote reepithelialization and healing in some of these cases. So overall, we're seeing some great results with the material. We've just recently completed some larger studies, which I won't get into all the details of here, but we're finding it really effective at treating some of these very difficult chronic wounds with very high percentages of closure. So it's really offering a new tool in the toolbox for folks who are dealing with chronic wounds, and is really just sort of rethinking how we can use engineered materials as an effective tool and therapy for treating some of these very difficult wounds. So with that, just very excited to share our success and our story in bringing this technology out of the laboratory here at WashU and into clinical practice, and just really excited to see where this technology can go and see what other ideas folks have for other applications of the technology moving forward. So with that, I'll pause and would love to see what questions I can answer.
Yeah, thanks, Matthew. So let's see. People, again, feel free to unmute yourself to ask a question, or you can put questions in the chat box.
Hey, Matt, I have a question. Justin Sachs.
Sure.
Have you looked at, so when you have these large full thickness wounds, which go down to exposed structures, and you place the Restrata on the wound. Do you also measure epithelialization? Do you see, have you looked at if epithelialization is more rapid with Restrata versus just standard, allowing it to heal to completion on its own? Do you have any insight onto how it interacts with the epithelium surrounding the wound?
Yeah, it's a great question. So actually, we're looking at some of those questions right now in a randomized controlled trial, actually comparing Restrata to standard of care in treating some of these difficult wounds. But what we are seeing is that in the case of reepithelialization, the fibers really offer almost a highway to bring those epithelial cells in and across the tissue, or in and across the matrix more rapidly. And so it can help promote and accelerate that reepithelialization in sort of wounds that have filled in and again, now just need to reepithelialize. Interestingly, if you put them in deep wounds, though, you do see the cells actually coming in through the material up through the base of the wound and actually integrating the material and forming new tissue in that matrix. And so again, depending on kind of where you place it, either deep in the wound or superficial along the skin, it does have sort of different roles, if you will. But overall, we see it. I think the main way that this material works is it just offers that bridge. It offers that structure that cells can grab onto and grow into and accelerate into the wound.
Let's at the moment go on to Dr. Sachs. So Dr. Sachs will tell us about his path to commercialization for a device and a system for preventing pressure ulcers.
Okay, great. Thanks so much. Let me share my screen here. All right.
There we go.
So that's our team. That's our title. Next slide. Those are my disclosures. Next slide. Okay, so Bohr's quadrant is like electron shells, fundamental understanding. Edison's quadrant, inventing the light bulb, we put together everybody, but it's not really getting into sort of the fundamental understanding of electricity. But Louis Pasteur, father of modern virology, pasteurization of milk. These are applications where you understand things down to the atoms, and then at the same time, you can scale them to billions of people. So these are the kind of ideas that if I'm going to get involved with, if I'm going to bring people into a team, I want to head towards Pasteur's quadrant. So something that you can get some good fundamental understanding on and then scale to the entire planet. So next slide. So that's the gravitational constant, 9.81 millimeters per second squared. So at the surface of the Earth, that's the acceleration of your body going down into the Earth. So if you're in space, there's no gravity, but on the surface of the planet, we have gravity, which has consequences in medicine. So next slide. So in the recumbent or supine position, or if you're seated right now, so right now, you can feel your ischial tuberosities, if you're not moving around, driving down into that chair. So this is an example of a patient laying in a hospital bed, let's say on a ventilator, not moving, and literally there is pressure, force, equal mass times acceleration, going against the back of the head, the shoulder, the elbow, and really in a patient in the hospital, there's a lot of pressure at the sacrum and at the heel. And what can happen over time is you can cause ischemia, which is the decrease of tissue perfusion to skin, soft tissue, fat, muscle, and even bone over time. Next slide. So in 2008, Centers for Medicare and Medicaid Services actually created a list of never events in the inpatient hospital setting, such as wrong site surgery, leaving a foreign body in the patient, central line infection, and one of the other never events is a pressure sore or a pressure injury. So if you walk into the hospital and you are sick, or you have an operation, and you get sent to the recovery room, you go to the floor, or you go to the intensive care unit, and you develop a sacral pressure injury. So you wind up with, dead tissue or ischemic tissue. Ischemia means decreased blood supply. That's actually considered a never event. And those happen routinely in academic medical centers, in private hospitals, in nursing homes all over the country routinely. And that's considered actually a never event by CMMS. So literally not only does the hospital sort of get penalized, but you don't get reimbursed for some of the care that you have to outlay to fix these problems. Next slide. Get the next slide. So this is from the Agency for Healthcare Research and Quality. They oversee a lot of quality data in hospitals in the United States. So literally they call the cost to the healthcare system per year almost $12 billion. They've averaged the cost per pressure injury to be about $43,000, and there are about 2.5 million of these pressure injuries per year in the health. If you look at the in total healthcare system, 2.5 million pressure injuries at a cost of around $43,000 every injury that patients undergo. Next slide. So the problem, as I've defined it, is not all. It's a problem of care, and it's a problem of patients' physiology working together. So not everybody gets a pressure sore, and not everybody's at risk for a pressure sore, but certain patients are, depending on the length of the hospital stay, the length of their operation, their body mass index, whether or not they're on vasopressors, which are chemicals to increase or decrease blood supply. So the problem here is that this is what a pressure injury is. And I'm just showing a sacral injury. So these are stage 1, 2, 3, 4 pressure sores. And you can see on the back of the buttocks that's literally dead skin and fat. And that's literally just the tip of the iceberg. That's when we get called upon to debride this tissue, and as a plastic surgeon, I routinely take care of pressure injuries all the time. We get consulted about them in the hospital. I see them in clinic. Patients refer themselves in. So it's not that just the skin and the fat dies, but the muscle can even necrose below from these pressure injuries. And when you have necrotic tissue in the body, what happens is that can get infected, that can get into the bloodstream, and patients can get very sick. That's when you get bacteria in the blood, or sepsis when the bacteria is responding and causing multi-organ system failure. So pressure over time causes pressure injuries. Next slide. So our solution, there's different types of solutions. There's pressure beds, large beds, which are very costly, which offload pressure and also can give you some idea about millimeters of mercury pressures in the region of the patient. But our solution, our plan, is to have created this wireless device, this flexible device. We call it the Mercury Patch, for millimeters of mercury. And what it essentially is integrated force, like force equal mass times acceleration sensors, which are integrated into a flexible silicone sheath with flexible electronics. And this is, the information is wirelessly transmitted to an agnostic Bluetooth device, such as a smartphone or a tablet. Next slide. And you can see here, this is just a device again in its current iteration, which is, we have the current stable form factor of this in our collaborative group. It has the sensors, it has built-in microprocessors. It's able to adhere to the skin, and it's able to, it's waterproof. So oftentimes there's body fluids in that region, there's moisture. So it's a lightweight, flexible, integrated biosensor that goes over bony prominences that reports in real time pressure data to healthcare providers. And if you think of like a vital sign, so there's temperature, pulse, blood pressure, pressure over bony prominences in supine patients that are intubated, asleep or not moving. That's literally like another vital sign that we don't have, that we would like to add to armamentarium here in the healthcare system. Next slide. So, once again, just sort of showing off the device. And, when I got here a year and a half ago and meeting Matthew, we spoke about this idea, this concept, and we were able to collaboratively come up with John Rogers up in Chicago, a device that sort of fit these criteria of what we wanted to do. And this is our device. You can see it's flexible. We have an application that interfaces with a smartphone, and it gives it, you can get data in real time and just watch the pressures coming off of each of the sensors. So this is a little bit of a novel concept. Next slide. And so when we look at the competition, if the best thing that you could have is continuous monitoring, real-time feedback, measures pressure, it's low cost, it's seamlessly integrates into workflow, and we've been able to confirm that it works. Standard of care is low cost, and that's what nurses and physicians do right now. But you don't have that real-time feedback, so you're just essentially trying to turn patients every couple of hours. Nurses often have multiple patients to take care of, and we don't really know what's happening at the interface in the sacral or heels for a very obese patient or thin patient. So there's other devices that are out there, heat mapping systems, devices that ring a bell when at times, other pressure systems such as the MAP system, which is a large mat that is on the orders of $20 or $30 or $40, $50,000. So these are very some of these devices are very costly, and also the hospital beds that you have can be up in the hundreds of thousands of dollars with integrated sensors. So the Mercury Patch, or our lightweight pressure patch, is a inexpensive, novel way to measure pressure at the bony interfaces. And so we feel that we have a little leg up on our competition as we start to roll this out into a clinical trial, here at the hospital. Next slide. And the opportunity that I see it also is, so we often take our patients to the operating room. We put them asleep for 5, 6, 8, 10 hours. I mean, today I did an operation. We started at 8 o'clock and I was finished at 3:30. That patient was laying flat on their back for hours, and there was pressure building up on the sacrum. They're a healthy patient. They're going to be walking tomorrow, but take that same patient at risk. If they were in a more advanced operation, they might be on a ventilator for a couple of days. We're creating risks in the operating room by building up pressure over these bony interfaces. So it'd be nice to finally have some objective data. So maybe we can correlate what we find in the operating room to what we find in the clinic, and also what we find on the floor. So it's a big market because there's millions and millions of surgeries every year, and there's millions of types of patients that come out of these operating rooms to ICUs. So there's a huge opportunity for us to get more granular with the data that we are able to get at the interface between the sacrum, the heel, even the back of the head while they're in the hospital, because these pressure injuries are happening. At WashU, there's about a 10 or 12% rate of pressure injuries per month on patients that come through the ICU, all ICUs inclusive. So we're not resistant to these pressure injuries here in this healthcare system and in other healthcare systems where I've been at. Next slide. So because this is a venture cafe and we have a great group here, we're optimizing our device production. We are getting ready for human clinical testing, and we're looking forward towards probably a class 1 regulatory pathway at first. So we've optimized our device. We have a working prototype that measures pressure. We're going to be doing some healthy volunteer studies in the next couple of months. Amanda Westman's going to help lead that with myself. We have an IRB approved to do first in human study with the device, where we'll go to the operating room and measure pressure on the sacrum in the operating room. No intervention, just measure sacral interface pressures. And then as we think about the device moving forward, I think as long as we want to try to work towards a rapid regulatory approval. So at this point, love to hear some discussion questions about sort of what would be the quickest pathway to regulatory approval. The only issue that I bring up is if we decide to come up with an algorithm that dictates when we're going to turn patients based upon the pressure data. That's going to potentially change our regulatory, our path. So next slide. And then I just show this because to conclude, this was from a book chapter that I was a co-author on that we put together, and kind of we're in the valley of death right now. We have some early funding for this pressure device, and we're starting to do our R&D trials, and we're looking to raise non-diluted funds through the DoD and potentially SBIR in order to help fund a larger clinical trial, which will roll out here at Barnes-Jewish Hospital in the ICU where their high-risk patients are, to measure the pressure interfaces to see if we can correlate what we're finding to the pressure injuries. And if we are able to be successful correlating the high pressure injuries with our device, then our next step is the intervention, which is where we can start turning patients at different intervals. Because right now the current recommendations for turning patients are classic is every 2 hours, but that's might not be working because we still have all these pressure injuries across the whole healthcare system in the United States. So turning is not the only solution. Understanding what happens at the sacral interface or the heel interface or the occiput in the back of the head to prevent these pressure injuries is going to be a critical next step in trying to get rid of these 2.5 million pressure injuries per year, which come out of the hospital system. And actually, I didn't mention it before, but it's actually the second highest lawsuit claims besides wrongful death. So there's wrongful death claims, and then there's pressure sore claims, and it's probably a multi-billion-dollar legal industry per year. So we're kind of flying in the blind now with sacral interface pressure. So the Mercury Patch is a potential solution that we think is going to maybe help change sort of the workflow here in our healthcare system and give us an additional vital sign that we can use to help our patients and reduce the never events of pressure injuries. Next slide. So thank you. That's that.
So thanks very much, Justin. And well, I see that we're coming up to the end of the hour, and but I would like to remind everyone that contact information for both of our speakers can be found on our website. And also just, I hope to see everyone on May 20th when we'll hear from Hong Chen and Adel Chaudhry from the WashU Department of Radiation Oncology, and they'll tell us how ultrasound can be used for molecular diagnosis of brain cancer. So once again, thanks to both speakers for the very interesting talks, and I hope everyone enjoyed it.